Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The feature presentation today is a cardiac evaluation for non-cardiac surgery. Besides seeing patients with coronary artery disease, the second most important consultations I used to receive during the past 40 years is for cardiac evaluation of a patient going for non-cardiac surgery. It becomes exceedingly important for us as cardiologists and also for primary doctors to understand what is the cardiovascular risk for a patient going for general surgery or a non-cardiac surgery, be it a very minor outpatient procedure to like repair of a triple A or pneumonectomy, something like that. So let us delve into the feature presentation and learn how we navigate through the various aspects of evaluating a cardiac patient for a non-cardiac surgery. More than 50 million elective surgeries are performed in the United States each year. The major perioperative cardiovascular events occur at a rate of 1.4% to 3.9% of the surgeries, despite most of them having gone through cardiac evaluation. So that underscores that there are so many factors that we need to take into consideration before surgery, during surgery, and in the immediate postoperative period. Because there are certain things that happen during surgery which we cannot predict, like development of cardiac arrhythmias, unexplained hypotension, bleeding. All of these things can adversely change the cardiovascular risk intraoperatively. So, preoperative assessment of patients is exceedingly important to make sure we keep these cardiac events to minimum, and hopefully the patients can go home safely after their procedures. Okay, first we need to evaluate the patient about his cardiovascular status. What is the underlying cardiac condition? It may not be coronary artery disease, but the person may have hypertension, the person may have vascular disease, the patient may have diabetes. All of these risk factors, or high cholesterol, all of these risk factors come into play when we evaluate a cardiovascular patient. The second thing is, if the patient has cardiovascular problems like coronary artery disease or heart failure, what is their functional status? Do they have an acute cardiac process going on, or do they have a stable cardiovascular condition even if it's heart failure? So, first of all, we need to find out what is the underlying cardiac condition. Does this patient have coronary artery disease? If this patient has coronary artery disease, is this stable? Does the electrocardiogram look okay? Or does this patient have signs and symptoms of acute coronary syndrome? Next, heart failure. Heart failure is a very common accompaniment of cardiac patients, whether they have hypertension, valvular heart disease, or coronary artery disease. And when they have heart failure, we need to find out what is the status of their New York Heart Association classification status of their heart failure. Are they compensated or they decompensated? Now, next, valvular heart disease. Of course, when we are talking about valvular heart disease, we are talking about two major components. One is the functional significance of the valve stenosis or regurgitation or the prosthetic valve itself. And the second thing is the anticoagulation. Are these patients on anticoagulation, and how do we manage these anticoagulations before, during, and after surgery? Cardiac arrhythmias. Cardiac arrhythmias can suddenly crop up during intraoperative phase. If somebody develops atrial fibrillation with rapid ventricular response, that can drop the blood pressure, cause myocardial ischemia, and all kinds of things. So cardiac arrhythmias need to be evaluated to see is the patient. Cardiac evaluations need to be evaluated to make sure, is the rhythm stable? Is the heart rate stable? Is the rhythm controlled with medications? And should we continue the medications in the perioperative phase? Pulmonary vascular disease comes into play when we are dealing with the patients with the primary lung problems like COPD or emphysema or asthma, but also from the left side of the heart when you have heart failure, which can cause pulmonary hypertension. How bad is the pulmonary hypertension? How flexible is a pulmonary hypertension. This is like a fixed pulmonary hypertension. All of these things play a role in evaluating patients with the cardiovascular disease for non-cardiac surgery. Now, once we identify the cardiac status of a given patient, the next question we need to ask is, what kind of surgery are you having? And based on that, we can categorize them as low risk, that is less than 1%, or 1 to 5% risk of cardiovascular events. Mainly major cardiovascular events are MACE, myocardial infarction, or heart failure, or death, all these things put together. Or is this a high risk, more than 5%? So some are like patient going for dental extraction, eye surgery, reconstructive surgery, carotid asymptomatic, and breast surgery and superficial surgery. They all fall under less than 1% risk, and they need minimal cardiovascular evaluation. As long as they are stable, even if they have coronary artery disease or heart failure, they should be able to go through these procedures, including minor orthopedic surgeries. The intermediate group is the one where we need to be a little more cognizant of what is their underlying cardiac condition, what is their functional status, what kind of surgery they're going for, and how do we prepare the patient for such a surgery with intermediate risk of 1 to 5%. If it's a high-risk patient like aortic or major valvular heart surgery, or pancreatic surgery, or pneumonectomy, total colectomy, and these are all major surgeries which needs thorough cardiovascular evaluation to assess their risk, their functional status, and see how best we can get them through these surgeries. In order to assess the cardiovascular risk, which I was talking to you about, is this less than 1%, 1 to 5%, or greater than 5%, you can visit this the surgical risk assessment website, riskcalculator.facs.org, and you can plug in all the numbers, the age, the sex, the blood pressure, the cholesterol level, underlying cardiac condition, and what kind of surgery this patient is having, and it will give you the result as to what is the cardiovascular risk. And based on that, you can categorize them into either low risk, intermediate risk, or high risk. So this is a great way. Please mark this site. It becomes exceedingly useful for you to evaluate their risk. And if you are an internist, and if you're dealing with a patient with moderate to high risk, it is best to refer them to cardiologist so that they can evaluate these patients, assess their functional status, and also make sure their cardiovascular medications are optimized before they go for non-cardiac surgery. Okay, let's begin with the surgery itself. The first question we want to ask is this an emergency surgery? Does this patient need to go from the emergency room to the operating room? If the answer is yes, no further cardiac evaluation needed. Maybe if we have time, we can get an electrocardiogram. And while the patient undergoes surgery, we'll look through their records, evaluate their cardiovascular status, and in the immediate post-operative phase, we try to stabilize these patients the best way we can. If the surgery is emergency, there is no contraindication to surgery, and that surgery takes preference over any underlying cardiac conditions, except if you're dealing with an acute myocardial infarction. And it has happened. People have been rolled into the operating room for gallbladder surgery, and long behold, someone ordered the EKG and find out this patient is having an acute inferior myocardial infarction. And those cases are rare, but I'm just giving you an example. Okay, if this is not an emergency surgery, then is this patient having an acute coronary syndrome or an unstable cardiac status? For example, it could be coronary artery disease with ischemic changes on the electrocardiogram, some chest pain, or it could be heart failure with shortness of breath with minimal exertion, pulmonary congestion on examination. So all these things are telltale signals of decompensated patient, or a patient who is not stable. If the patient has an acute coronary syndrome, then we go down this step, which will be in the next slide. Whereas if the patient has, then we can evaluate them accordingly based on the presentation with an electrocardiogram, maybe an echocardiogram or a stress echocardiogram or a nuclear stress test, and optimize their symptoms with medications and whatever needs to be done, and then proceed with the surgery based upon what is their cardiovascular risk. Is it low, intermediate, or high risk? Okay, here are some examples of emergent surgery. Limb-threatening ischemia, which needs to be operated on, like acute ischemic limb due to embolization within 6 hours, or an urgent threatening like 6 to 12, 24 hours. Time sensitive, like, there are certain cancer surgeries which needs to be done within like 2 to 4 weeks. You can't wait for 6 months if they have a metal stent or a drug-eluting stent. So these things come into play. It is very complex maze of events that we have to look into before we say the patient is stable enough to proceed with non-cardiac surgery. If a procedure can wait for a year, if the patient has a drug-eluting stent, you rather keep them on antiplatelet agents for 1 year before you do the elective surgery. Okay, now coming back to the slide that we were working on here, this part, now we're coming to estimate perioperative risk maze based on clinical findings. Now we're going to pick up there. We pick up here, estimated risk. If the risk is less than 1%, as I said, you can go to that surgery site and plug in all the numbers and see what the risk. If the risk is less than 1% and there's no more further testing needed, they can proceed for surgery. If the risk is greater than 1%, like intermediate risk or high risk, then we need to evaluate their functional status. If they can exercise for 10 minutes, 10 meds, that means we don't need any further testing. Or if they are between 4 to 10 meds, even then, if this is a class 2B indication, they should proceed for surgery without doing any further procedures like cardiac catheterization or coronary intervention. But if we cannot assess their functional status, at least we need to assess their myocardial perfusion status, which can be done using pharmacological stress testing with nuclear imaging. It will tell us if we are dealing with an area of significant myocardial ischemia that can jeopardize the patient in the perioperative phase or intraoperative phase. So based on that, we evaluate these patients. If the stress test is abnormal, we may proceed with cardiac catheterization and consider interventions. And when we talk about interventions, again, we have to think about it. If you're just doing plain balloon angioplasty, you may be able to do the surgery within a month. If it's a bare metal stent, after 30 days of antiplatelet agents, you can do the surgery. If it's a drug-eluting stent, then it's a different story, which we will cover in the subsequent slides. Okay, here is a 2014 ACC AHA cardiac evaluation for non-cardiac surgery guidelines were published, and this is the flow chart. It is very complex, and even I can't read it just sitting inches from the screen. But what we're going to do is we are going to simplify this. First, let us take this part here and try, because this is much simpler. When we break this down, it becomes so easy to understand and see what needs to be done. So let's focus on this part now. And here is an expanded version of that one. We have a patient here. Needs emergency surgery, done deal. Proceed with surgery. No, does not need elective surgery, exhibits evidence of acute coronary syndrome. I already talked about, we need to proceed with evaluation of acute coronary syndrome like any other patient we would do who walks into the emergency room. We get an electrocardiogram, we check for cardiac enzymes, we may do an echocardiogram to evaluate their functional status, and some stress test to evaluate if there is reproducible or inducible ischemia. Then we proceed accordingly. If it is not, then this goes on the other side. We'll see if the perioperative risk is less than 1%, it's an elective surgery, non-cardiac surgery. If the perioperative risk is less than 1% based on that evaluation we did on that website, then we proceed with surgery. Now we're going to focus on this second half of this complex algorithm. Let's see what we can find out here. Needs non-cardiac surgery, no evidence of ongoing acute coronary syndrome. So we don't have an acute patient or a decompensated patient. So if the perioperative risk is less than 1%, by evaluating this patient's condition based on the history and lab tests, proceed with surgery. If the perioperative risk is greater than 1, so that means we are talking about moderate to high risk patients. So in these patients, we need to evaluate their functional capacity. If we don't know their functional capacity, then we may have to do like some kind of a stress test or a chemical pharmacological stress test to evaluate their left ventricular perfusion and function, especially ejection fraction. If the functional capacity is poor, again, we need to evaluate how bad is it. Is the ejection fraction 15%? Is the ejection fraction 20%? That puts them into high risk category. But it is important to know what their category is so that we know how to deal with them in the intraoperative and postoperative phases. If the functional capacity is good, proceed with surgery. If the functional capacity is excellent, then you proceed with surgery. All right, diagnostic tests. We have a handful of diagnostic tests that we can perform in evaluating cardiac patients for non-cardiac surgery. Of course, we have the standard electrocardiogram, which every internist has a machine in the office. Hopefully, they can do an electrocardiogram. If the reading looks to be normal, that's well and good. If the reading is abnormal, showing signs of hypertrophy, strain, and a lot of ectopic beats, then it may be a concern. The other test we have is the echocardiogram, either just a resting echocardiogram or a stress echocardiogram, combining with exercise, dobutamine, or any kind of other type of exercise like a bicycle, hand grip. Then we have a regular treadmill test, which is simpler. Actually, the treadmill should have come before the echocardiogram. And if the patient is not able to function and cannot exercise, we can use pharmacological tests combined with the nuclear myocardial imaging. And if there is any evidence of ongoing myocardial ischemia of a significant degree, greater than 10% of the myocardium, then we may consider cardiac catheterization and proceed accordingly. So let us look at what are the conditions. A patient going for surgery, a preoperative 12-lead EKG is reasonable, especially if they have a history of coronary artery disease. I mean, it's no-brainer. If somebody has a history of coronary artery disease, you want to know an EKG, and you want to compare that EKG to the last EKG the patient had. If they look the same, is stable, no significant changes in the STT segments, then that's well and good. If they have structural heart disease, for example, hypertrophic cardiomyopathy, or heart failure, or mitral stenosis, aortic regurgitation, aortic stenosis, it's reasonable to get a 12-lead electrocardiogram. And you may consider an electrocardiogram in most patients except the low-risk patients. Exercise testing, I already talked about where we would do an exercise testing in patients with acute coronary syndrome, where we are not certain if the symptoms are related to the heart or it could be something else. Then we need to do some provocative tests to see if there is reversible ischemia. Then we need to assess their functional capacity. What can this person do? Can you walk 2 blocks? Can you go 2 flights of stairs? So there's a demarcation like 4 METs. What are the things that amounts to 4 METs? 4 METs is a good benchmark to see how well this person is fitted. If they can climb 2 flights of stairs, walk uphill, run a short distance, do heavy work in the house like scrubbing floors and all these things, that means you are doing more than 4 METs of exercise. And if you're like swimming, tennis, basketball, skiing, you're close to 10 METs of exercise. If you're doing these kind of activities and you're going for a non-cardiac surgery with a risk less than 1%, no cardiac further evaluation, an electrocardiogram may be ordered, but there's no other test needed to decide if this patient is ready for cardiac surgery, non-cardiac surgery. Echocardiogram. Echocardiogram is not something that we should be ordering in every patient. That is a no-no on echocardiography board. I'm sure there is always going to be one question about indications for echocardiography in cardiac patients, either going for evaluation or for preoperative evaluation. The only time you would order an echocardiogram is if you want to know if the patient is having shortness of breath and if that shortness of breath is related to cardiac status. Does this patient have a reduced ejection fraction? Does this patient have hypertrophic cardiomyopathy? Does this patient have heart failure? So these are the conditions where you would order an echocardiogram. And again, we can also combine the echocardiogram with like stress modalities, which I talked to about, like treadmill exercise, dobutamine, or bicycle exercise to evaluate not only their anatomy, their valvular structures, but also the functional status of their heart in terms of ejection fraction and myocardial function. Now, cardiac catheterization is rarely indicated, but it is in patients who have like critical aortic stenosis or severe mitral regurgitation or mitral stenosis, who are going for procedures like intermediate risk. In those patients, the cardiac evaluation must be completed before they go for the surgery, because their conditions can get rapidly worse during the intraoperative or perioperative phase, which will put them into more danger than if they had cardiac evaluation before and it was addressed before the elective procedure. The next thing we focus will be blood thinners. Majority of the cardiac patients are on antiplatelet agents like aspirin or Plavix or any other antiplatelet agent. They may be on blood thinners like warfarin or a whole number of new blood thinners because of coronary artery disease, cardiac arrhythmias, or valve replacement, and now we have to deal with these blood thinners. Let's talk about antiplatelet agents used in patients who undergo coronary stent placement. If the patient has a coronary stent, if the stent implantation was less than 4 to 6 weeks, if this is an elective surgery, you need to delay the surgery for 365 days. That is class 1 indication. However, the surgery can be done within 6 months, around 6 months period, if it is urgent, like cancer treatment or something that cannot wait, or a complication develops. You're waiting for gallbladder surgery, then a complication comes up, then you may be able to do that before 365 days. If the person has a drug-eluting stent and you're between 30 days and 365 days, then we have to evaluate the surgical risk versus the bleeding risk. As I said, after 6 months, we can reasonably stop these antiplatelet agents, do the surgery, and resume the medications as quickly as possible. And if we can delay the surgery, you would prefer to wait at least 365 days or a minimum of 6 months before proceeding with surgery. Now let's continue down here and see what this one shows. If drug-eluting stent is greater than 330 days but less than 365 days, no. Does the patient need to continue or discontinue P2Y12 inhibitors? If you can continue the antiplatelet agents, it is preferable to continue the antiplatelet agents. But if for some reason you need to stop the antiplatelet agents, at least we should be able to continue aspirin alone and then resume the antiplatelet agents as soon as the surgeons clear the patient for antiplatelet therapy. This we already covered. If they had balloon angioplasty, they can go for a surgery within 14 days. This is sort of maybe a stopgap, I would say, in order to salvage the patient. And if they have a bare metal stent, it can have them on antiplatelet agents for 30 days, and after that they can go for procedure. But if you have a drug-eluting stent, ideally 365 days, but if it's urgent, semi-urgent, then can be done after 6 months with some caution. And there are patients with valvular heart disease who are on warfarin or something similar to that. Then we have to depend upon if low risk, medium risk, or high risk. If we are dealing with, when we talk about risk, we are talking about risk of embolization. So if the risk of embolization is small, there's no need to bridge the anticoagulant. So we can proceed. If the risk is medium to high, then we may consider switching them over to low molecular weight heparin or unfractionated heparin in the immediate preoperative phase and intraoperative phase. And then as soon as the condition becomes stable, we can resume them with low molecular weight heparin and switch over to the long-acting antithrombin agents. Talk about cardiovascular drugs. Cardiovascular drugs are important. There are a lot of times the patients are put as NPO, nothing by mouth, and that's the worst thing that you can think of in a cardiac patient who is going for a moderate to high risk surgery. These cardiac medications are extremely important in maintaining their cardiac status and also maintaining their heart rate and rhythm, especially if they are being treated for arrhythmias. Same thing with blood pressure. So ideally, you want to continue the medication, like beta blockers. We should not stop the beta blockers abruptly before the procedure, but you do not initiate a beta blocker in the perioperative phase until the patient's condition is stable. Statins. You can continue the statins if they are chronically on it, but consider patients with clinical indications undergoing elevated procedures. We can start them, but it's not an emergency. Alpha agonists. You do not start an alpha agonist immediately before surgery because you don't know how the patient is going to respond to the medications. ACE inhibitors can be continued. However, we need to closely monitor the kidney function because in the intra and perioperative phase, due to fluid shifts, the intravascular volume can get contracted, which can make the creatinine go up, and hence ACE inhibitors can sometimes be tricky if the kidney function continues to deteriorate. So that's what we need to focus upon. Aspirin can be continued in most cases, but if it is absolutely necessary, we can stop it and resume as soon as the surgeons say it is okay to continue that. We already talked about beta blockers, angiotensin converting enzyme inhibitors. It's reasonable to continue these medications in the perioperative phase. So ladies and gentlemen, this is a very quick synopsis of how you evaluate a cardiovascular patient, what is the underlying cardiac condition, what is your diagnosis, what is the functional status of this patient. Is this patient stable or unstable? What is the nature of the surgery? Is this urgent surgery or elective surgery? And then what kind of surgery is this with a risk factor less than 1%, 1 to 5%, greater than 5%? Then you do the functional evaluation of cardiovascular patients and then finally follow them meticulously with their medications and any evidence of complications after that so that you can minimize perioperative complications arising from a cardiac status. Thank you so much for watching this presentation. We have numerous videos on cardiovascular education for the physicians, internists, and also for the general public. Please do watch them and please do subscribe to our YouTube channel, and I will see you in the next video.